After the beautiful video by Abhijit, we'll now talk about premium IOLs in cataract surgery in patients who have pseudo-exfoliation. I would like to thank the scientific committee. I'd like to thank all of you for being here and the chair over here. In my practice, now I've almost totally shifted to offering my patients either these trifocal IOLs or EDOF IOLs. Unless otherwise warranted, I'm not giving my patients monofocal unless otherwise they cannot afford at all. But I always give them the option of EDOF, and we have cheaper Indian companies are also making very nice EDOF IOLs, which are much cheaper, and the trifocals are also by Indian companies. So more or less, I've shifted to premium IOLs, and the patients are very happy. And slowly a time will come when your patients will come and tell you that they want a EDOF IOL and they want a trifocal IOL, because right now the patients are pretty confused of what is premium and what is a regular IOL. But that day will come soon. And in your practice, you will come across these patients who will have pseudo-exfoliation. And as we all know that the zonules are weak and we have to take special care in these patients. The most beautiful things in the world cannot be seen and even touched. They must be felt with the heart. And what am I talking about is the zonules behind the iris which you cannot see. And especially in these cases of pseudo-exfoliation, when you don't see the zonules and you are seeing the pseudo-exfoliative material on the anterior capsule, on the iris margin, it is best to put a CTR in these patients. Several studies have shown of the entire IOL bag complex descending into the vitreous many years even after the surgery, especially in cases of pseudo-exfoliation where adequate support techniques were not used. Because even when we are doing the surgery, we are putting the stress on the zonules. As it is, they are compromised from before, and we hurt them more and the zonules become even more weaker. There are several reports have shown that CTR implant reduces the intraoperative complications of pseudo-exfoliation eyes, suggesting the use of device in cases of mild zonulopathy and phacodonesis. While these pseudo-exfoliation cases have several complications can happen preoperatively, intraoperatively, and postoperatively, we will now focus on the IOL in the bag dislocation, which is one of the most dreaded complications which can happen, especially in pseudo-exfoliation in total IOL in the bag dislocation. There are weakened zonular apparatus. And why are we so concerned? Because even on that day when you're operating, when everything goes smoothly and the IOL is right centered in the bag, still it's a progressive zonulopathy. Once you have seen the thing on the IOL, on the iris margin, once you have seen the exfoliative material on the anterior capsule, remember that this is a progressive zonulopathy, and even if everything is all right today, that's not a guarantee that tomorrow things will not be all right. There may be capsule rupture and there may be zonular dialysis also. The degree of zonular laxity does not strictly correlate with the amount and extension of the pseudo-exfoliative material visible over the lens, but more with the age of the patient. The more the patient is older, the zonules will be weaker in addition to what was happening with the pseudo-exfoliation material which was there. The typical signs of zonular weakness are phacodonesis with eye movements and sometimes a reduction of the anterior chamber depth due to forward shift of the lens, which we are all aware of. In addition, there is increased weakness of the zonular apparatus. There is limited pupillary dilatation at times. There is more risk of vitreous loss, several times higher, especially from the sides it can come. So once you are operating these patients in the operating room, these things should be available right at that point of time, like high molecular viscoelastic device, the iris retractors, the ring dilators, and the capsule tension ring. And at that point of time, once you feel that the bag is constricting or contracting, and that time if you look for a CTR and the CTR is not available in your OR, the things can become quite disastrous. And all these things, if you use, it reduces the risk of intraoperative complications. As I said, there may be vitreous loss, there may be nuclear luxation, there may be bag decentration, and dislocation of IOL with the time. This video was not running properly. So, though the CTR may make it difficult, surgeon must use a capsular tension ring to support the capsular bag during cortical cleaning and IOL implantation. Once you see the capsule is contracting and you still have some zonules, some cortex remaining, it may be a good idea to put the CTR, especially in these patients who have pseudoexfoliation. Those who do not have pseudoexfoliation, you can put the CTR later also. But once you are doing the stripping of these cortex in patients who have pseudoexfoliation, it's a good idea to put the CTR even before removing the cortex. Otherwise, you may pull the whole bag together because the zonules are weak. Tangential stripping in combination with gentle centripetal traction should allow accurate cortical removal. And in case of extensive zonulopathy dialysis, more than one device may be employed is required. The capsule retractors help support the zonular lens complex in the anterior-posterior direction for facilitating hydrodissection and cataract fragmentation, while the CTR allows even distension of the capsular bag, supporting areas of zonular dehiscence by redistributing the zonular tension, allowing optimal IOL centration. The capsular phimosis with IOL decentration and late IOL in the bag dislocation are among the most dreaded complications occurring after the surgery, which is why CTR is so important. And capsular shrinking determines centripetal traction on weakened zonules, including tilt and decentration of the IOL with possible dislocation of the IOL bag complex. Now, the choice of the IOL implantation in pseudoexfoliation patients, it is related to the elevation of the state and the future risk of capsular instability. In presence of zonular weakness following a CTR implantation, a one-piece or a three-piece acrylic IOL may be implanted as per the surgeon's choice. IOL capture is also a good idea where it is unpredictable for future instability, which is always an issue. In these patients, we also have to keep in mind that there is increased endothelial cell loss in patients who have pseudoexfoliation, and there is also a chance of cystoid macular edema, so use of NSAIDs is also a good idea. Thank you so much for your patient hearing.
Thank you, sir. Very nicely put. Actually, in pseudoexfoliation and all generalized zonular weakness or zonulopathies, as you rightly pointed, CTR is a must.
Yes,
because later on you are going to have a capsular phimosis. Other thing is the timing of the CTR, as you rightly mentioned. So if you are dealing with a relatively harder cataract, it is better to put a CTR early because the chopping forces are going to further increase the zonulopathy. But if you are dealing with a relatively softer cataract, you may delay the CTR because CTR itself is going to cause a lot of problems like difficulty in rotation. Cortex aspiration becomes very difficult because then you have to use more of the tangential stripping forces.
Yes.
So as somebody has rightly put in that the CTR should be put as late as you can but as early as you must. So yes. So I've read it somewhere. It was a video on YouTube where they very beautifully had said this, that so CTR is one thing which is important, and then as you rightly said, what IOL you are going to put. So what is your take on putting multifocal IOLs in these patients?
Patient expectation is very high, especially in these days. But if you see a patient with pseudoexfoliation, it may be a good idea to avoid multifocal IOLs, trifocal IOLs. It is not a good idea to put in these patients, and you can explain to the patient that to use a conventional monofocal and use glasses after the surgery.
Another thing, a lot of studies are going on these days, is that people, they put a CTR in the bag and then they put a three-piece IOL in the sulcus and capture it. So then the bag is not going to dictate the term. The IOL gets locked in, so you have a longer term stability.
Yes.
So it's a good idea if you're putting a monofocal IOL, put in a CTR in the bag and put a three-piece in the sulcus and capture it.
Yes.
So long-term stability is much more.
Yes, yes. I've mentioned that.